He's professor of medicine at Harvard Medical School, chief of the MGH Metabolism Unit, and director of the Nutrition Obesity Research Center at Harvard. He has had a long-standing interest in the metabolic and immune complications of HIV disease, and has been on the WHO Technical Advisory Group on Nutrition in HIV disease, as well as chaired the AHA State of the Science Conference in CV disease in HIV-infected patients. He has a wonderful bio, but in the interest of time, I'm just going to talk about the fact that he has done a lot of research where he has shown efficacy with the growth hormone releasing analog to reduce excess hepatic fat, prevent fibrosis progression, and improve inflammatory and oxidative gene pathways. And he has been awarded the 2016 Arbach Laureate Award in Translational Research from the Endocrine Society. And we are looking forward to listening to him today. Dr. Grinspoon.
Thank you. Really, thank you very much for inviting me. And it was a special treat to listen to an interesting case. So thank you very much for that. So I'm going to talk today, as you mentioned, about a novel hormonal strategy to treat non-alcoholic fatty liver disease, or NAFLD, and I'm going to discuss the mechanistic and therapeutic considerations of this. In terms of my disclosures, they're listed here. And in terms of the outline, I'm going to give you an overview of NAFLD epidemiology, albeit brief, because you probably know much about that already. I'll talk a little bit more about the mechanisms of NAFLD-NASH, and then I'll focus on disrupted growth hormone signaling in liver disease, and edge my way into a discussion of HIV as a model of acquired ectopic adipose and reduced growth hormone, and talk about a unique application of this GHRH, growth hormone releasing hormone agonist for NAFLD, that we showed to be efficacious in an HIV population, and then talk about future directions, perhaps in a non-HIV population as well. So as you all know, NAFLD represents a spectrum of disease, starting from simple steatosis, progressing on to steatosis and lobular inflammation, NASH, and then through mild fibrosis, advancing fibrosis, and cirrhosis, and ultimately, in a small percentage of patients, hepatocellular carcinoma. Along the way, there are different mechanistic factors. I'll focus particularly on the steatosis as I go through the rest of my presentation, but there are inflammatory pathways, fibrotic pathways, etc. And you can see in the bottom through the different slides, there's different histological observations in terms of primarily fat accumulation, fibrosis, and ultimately bridging fibrosis and hepatocellular carcinoma. So NAFLD really is a manifestation of metabolic disease. This is just a slide showing that the prevalence of NAFLD tracks with the prevalence of obesity, and the United States is high on this curve, unfortunately. And NAFLD, with the advent of hepatitis C therapy, NAFLD is a rising cause of liver transplants, as shown on this particular slide. So NAFLD has become an intense focus of management. Unfortunately, at the moment, there aren't any drugs that are specifically approved. A few have had some efficacy, but none of the newer drugs have been approved yet for NAFLD. And it's really important to mention that NAFLD patients are at increased risk of cardiovascular disease. And you can see here, even just looking at patients with hepatic steatosis present or absent, there are differences in the cardiovascular risk with an adjusted hazard ratio of 1.72. And this is adjusted for ASCVD risk score, obesity, and metabolic syndrome. So it's not just that they are obese in general or insulin resistant, et cetera, but there seems to be other things that NAFLD represents that may be contributing to risk independently of those. So I want to spend a minute to talk about pathogenesis. NAFLD pathogenesis really represents a perfect storm. I kind of group it into two main buckets, prehepatic and intrahepatic. On the prehepatic side, you have conditions that lead to increased substrate flux, for example, obesity, especially visceral adiposity. You have insulin resistance, and I'll talk about its unique role. Intrahepatically, you see amongst patients with NAFLD, you see increased de novo lipogenesis, decreased lipid oxidation, and decreased lipoprotein export, all leading to increased triglyceride in the liver. So it's really important. You can't underestimate the effect of insulin resistance in NAFLD, but importantly, it's a selective hepatic insulin resistance in NAFLD. And in NAFLD, as you can see on the right, hyperinsulinemia through the insulin receptor drives de novo lipogenesis. And there is resistance to the suppression of gluconeogenesis, but no resistance to the activation of de novo lipogenesis. So insulin resistance actually contributes to de novo lipogenesis in NAFLD. And you can see I've illustrated from a paper from JCI some different examples of this. So in a control patient on the left, you have very little visceral fat, mostly subcutaneous fat, and very little intrahepatic lipid. If you have a lamin A mutation, for example, in lipodystrophy, you have severe insulin resistance, but signaling through the insulin receptor is ongoing. And in fact, in that case, the hyperinsulinemia drives through the insulin receptor, and there's a significant amount of de novo lipogenesis. And those patients with an adequate insulin receptor in the signal cascade, they have a significant amount of intrahepatic lipid. But take, for example, the contrasting situation of an insulin receptor defect in which there's insulin resistance, but signaling cannot happen through the insulin receptor. And in that case, you don't have very much intrahepatic lipid because of this phenomena I'm mentioning. So really, there's a significant consideration of insulin resistance driving de novo lipogenesis in these patients. Now I'm going to turn a little bit now to the role of disrupted growth hormone signaling in NAFLD NASH, and I'll circle back to some of the mechanisms shortly. So just to remind everyone, we just got finished talking about a possible pituitary aspect of that case, but the pituitary gland under the positive control of GHRH and negative control of somatostatin, I didn't really focus on ghrelin too much here, but that's also in the mix. Under these controls, the pituitary makes pulsatile growth hormone, which acts on the liver, which leads to transcription of IGF-1, which feeds back in the classical endocrine feedback loop. So in order to sort of assess what is the role of growth hormone signaling in the liver, I wanted to discuss one important paper in diabetes in which this group knocked out the GH receptor in the liver in mice. And in this situation, this third bar here, the LIGHRKO group, there was significant intrahepatic lipid compared to the control. And when in the HIT column over here, they overexpressed IGF-1. And that did reduce some of the steatosis, but it didn't bring it back to normal. So disruption of the growth hormone signaling in an animal model, specifically to the liver, leads to very, very significant increases in hepatic triglyceride. Now, this group also looked at other hepatic gene expression and pathways. And again, I'm comparing the black bar to the over furthest to the left to the kind of gray bar, third one in here. And you can see that the gene expression for lipid uptake genes, CD36, LDLR, et cetera, is significantly increased, as are the gene expression patterns for lipid synthesis and liver inflammation genes like MCP1, IL-1B, IL-6, et cetera. There is some improvement, but really very little with overexpression of IGF-1, at least on these pathways, lipid uptake, lipid synthesis, and liver inflammation. I'll circle back to the potential effects of IGF-1 on fibrosis in stellate cells in a minute, but that's not shown here. But this shows that disruption of GH signaling leads to increased lipid through potentially increased synthesis, and concomitant liver inflammation. Now, clinically, in adults with growth hormone deficiency, shown in this box here, you see a very, very significant percentage of people with NAFLD in the GHD compared to the control, 77% versus 12% in this study in the European Journal of Endocrinology. So, you really do see NAFLD in adults with GH deficiency. Now, there's really significant relationships between growth hormone, hepatic steatosis, and fibrosis. In a paper that we did that we published in JAMA, you can see a very significant relationship such that the hepatic fat fraction is increased as the mean overnight growth hormone levels are reduced. And growth hormone is also related to different levels of fibrosis, as shown here in this schema to the right. So there's tight relationships between fat fibrosis and growth hormone in clinical medicine. It's interesting to consider some of the mechanisms of growth hormone action in the metabolic pathways in the liver. And it's been known for a long time that growth hormone decreases de novo lipogenesis. And that's important to consider. It's shown in the lower right here, either in the fasting or the hyperinsulinemic state. As you add growth hormone, de novo lipogenesis decreases. So conversely, GH deficiency may be associated with increased de novo lipogenesis. It's also interesting to consider that growth hormone inhibits 11-beta-HSD1, which is important in the generation of cortisol. And that's actually an important pearl clinically to check cortisol levels when you give growth hormone. But in this instance, that may lead to reduction in liver fat, and conversely, GH deficiency may lead to the opposite. And in fact, you can see the effects of GH on 11-beta-HSD1, and you can see that liver fat content decreases with 12 weeks of an 11-beta-HSD1 inhibitor, shown over here in the upper right. So there's some interesting potential mechanisms of GH with respect to fat. When you look at IGF-1 in the circulation, you see that there's not much of a difference between people with steatosis present or absent. But when you look at NASH, there is a difference. And when you look at fibrosis stage, there's particularly a large difference. Again, I'm going to circle back to that IGF-1 may have different role than GH. GH may affect adipocyte control, whereas IGF-1 may be more targeting fibrosis. And you can see, though, with progressive disease, degrees of liver disease, circulating IGF-1 is reduced. You can also look at, this is a paper we published in the JCM, you can look at transcription. We had liver biopsy specimens, and IGF transcription decreases with steatosis, and it's also related to NAS, progressive increases in NAS score as well. Now, when you give IGF-1, this is a mouse model, but it's kind of interesting. This is recombinant human IGF-1 administered by osmotic pump in a diet-fed DB mouse, NASH mouse model. You see a little bit of an effect on hepatic triglyceride, but on necrosis in fibrotic area, you see a really significant effect, particularly on stellate cells. So again, getting to that theme that GH and IGF-1 may activate different aspects of the cascade in NAFLD. So to summarize this particular part of the talk, when you stimulate the growth hormone axis via GHRH or another mechanism, you get increased growth hormone in IGF-1, and the GH can lead to decreased fat accumulation, decreased lipotoxicity, perhaps an effect on inflammation, and the IGF-1 can lead to decreased fibrosis. All this may ultimately lead to decreased cirrhosis. And we know that hepatocytes express the growth hormone receptor, and we know that hepatic stellate cells express the IGF-1 receptor. So it's really an interesting biology, and this is a targeted approach in liver disease. So I'm going to turn a little bit to HIV as a model of abdominal fat accumulation, growth hormone deficiency, and NAFLD, and get more clinical as I progress. So the prevalence of NAFLD is very high in HIV, in this paper, in AIDS, shown to be 35%. And the risk factors include increased BMI, waist circumference, type 2 diabetes, and a high CD4 count. So pretty much as expected, but just a notable prevalence in this group. And it's interesting that the high CD4 count, not a low CD4 count, relates perhaps with recovery, weight recovery from initial disease. It's interesting to note that NAFLD is exaggerated in HIV. So NAFLD occurs at a lower BMI threshold in HIV than non-HIV. And it's also associated with increased steatohepatitis. This is primary NAFLD and HIV NAFLD. And you can see that the prevalence of NASH is higher in the HIV NAFLD. And that's true adjusting for age, sex, ethnicity, and BMI. So NAFLD can occur earlier and is exaggerated in HIV patients. I've spent a lot of time studying patients with HIV lipodystrophy. This is a very exaggerated case, but a guy I saw on the left in clinic. And patients with lipodystrophy can have abdominal protuberance, abdominal fat accumulation. They can have dorsocervical fat. They can also have loss of fat or subcutaneous lipoatrophy. In a paper we published in JADES a while back, if you look at people with normal weight or overweight at the same weight, so matching for weight, the patients with HIV have more visceral fat and less subcutaneous fat than normal weight control patients. So that's an interesting observation in this group of patients. And the accumulation of visceral fat is really important because really it's the excess intra-abdominal or visceral fat that so tightly relates to mean growth hormone. So as intra-abdominal fat area goes up, mean overnight growth hormone goes down. And this is true in HIV, in non-HIV. This is a physiological relationship. It happens to be exaggerated in HIV because of the increased intra-abdominal fat area. And in fact, when you look at this we published in the JCM a while back, when you look at the percentages of people with HIV lipodystrophy, HIV without lipodystrophy, so HIV lipodystrophy, the black, gray, HIV without lipodystrophy, and then the white is a non-HIV control group, using different cutoffs of a group with HIV lipodystrophy, GHRH arginine, you can see that it's a very high percentage would fail using that test, probably because of the intra-abdominal fat area. And in fact, if you control for BMI, it's the intra-abdominal fat, and you control for subcutaneous fat, et cetera, it's always the intra-abdominal fat that's most significant in that relationship. But it's true that even if you look in the general population, and this is another paper we published in the JCM, if you just, forgetting HIV now and just talking about a normal health population of patients, if you stratify based on obese, overweight, and lean, you can see that lean patients have a much higher area under the curve in a GH stimulation test. This is true based on obesity, and it's particularly true based on waist circumference. And you can see that the peak GH is significantly different in these groups. So overweight and abdominal adiposity, both in non-HIV and particularly in HIV, are associated with reductions in growth hormone. And in fact, excess visceral fat relates very, very tightly to hepatic fat percentages. And this is baseline data from a paper we had in Lancet HIV, and I'm going to circle back to this paper shortly. And in fact, one of the key markers of excess fibrosis in HIV-related NAFLD is the visceral fat content. So visceral fat is associated with excess fibrosis in this population. So what are the mechanisms of action of the agents under consideration for NAFLD-NASH? And this is true in HIV and non-HIV, but this particular list is going to focus a little bit on some of our work. But there are agents that are focused on lipid metabolism, fibrosis, and inflammation. And in NAFLD-NASH, at least, and I would have a different slide for the general population, but in NAFLD-NASH and HIV, there have been relatively few studies. Some have shown some effects, like pioglitazone was related to decreased liver fat. Aramcol was not an SCD1 agent. And Maraviroc, a Cenicriviroc type agent, had no effect on NAFLD. But the agent that has had the most effect to date is the study that we published, and I'm going to do a deeper dive in that because I think it has some particular significance for the general population as well. Before I get into that study, I wanted to spend a minute about selecting the optimal strategy to restore this sick growth hormone IGF axis I mentioned in liver disease. And as I mentioned, the pituitary is under control of GHRH and somatostatin, which lead to pulsatile GH and feedback. Now, you could just give growth hormone, but the problem with that is it doesn't lead to pulsatile GH, obviously, because you're giving it exogenously. And there's no feedback inhibition because you're giving the actual end hormone. In contrast, GHRH stimulates endogenous pulsatile GH, and the feedback is intact. In fact, the point of this is that we've shown in obesity versus control patients that the pulse generator is intact, but the peak pulse per area is off. And the idea with GHRH would be to restore this pattern from obesity or central adiposity to the control, the pattern you see in the control subjects. And a lot of people ask me, well, why not just give growth hormone? And the reason is that pulsatility matters. And this is a study, it's an old study, but it's very relevant. Here is our patients who are getting growth hormone. These are the deficient growth hormone patients getting continuous or pulsatile. And you're looking at palmitate as an indicator of lipolysis. And it's really pulsatile paradigms that lead to the increased palmitate concentrations. And in fact, signaling of the growth hormone axis through JAK-STAT is maximally stimulated via pulsatile GH, as shown here, as opposed to continuous GH. And that is exactly what we were trying to recapitulate using GHRH in our studies. And we worked with a biotech company called Therapeutic in this regard. And Therapeutic produced tesamorelin at our urging. This is a minimally modified GHRH 1 to 44 with a trans 3 hexanoyl adduct on the tyrosine. And this modification makes the analog resistant to DPP-4 mediated degradation. It still has a really short half-life, which is curious that you can give it once a day, but in any event, you can. And it increases GH in a physiologic pulsatile manner, unlike growth hormone. And it's given by daily sub-Q injection. This issue of feedback also feeds into safety. When you give GH, you typically have to titrate the dose, the IGF-1, whereas if you give GHRH, you never have to titrate because feedback inhibition is intact. It's actually a safer way to give growth hormone. Of course, you have to rely on an intact pituitary, which patients with HIV and functional GH deficiency of obesity have. This would not be a good drug to restore growth hormone in a pituitary patient who had been radiated, for example. It would be a very bad drug. But in the group that we studied, it made a lot of sense. And this just makes the point, and this is actual data, that you can restore this pattern of pulsatility when you give GHRH, and that with GHRH, you're having direct effects on the adipose tissue and then indirect effects via increased IGF-1. So I'll first start with the phase 3 studies for lipodystrophy. This slide represents 10 years of work. And basically, we had phase 2 studies, and we had 2 phase 3 studies The first of which was in the New England Journal, and then there were some collective studies in JAMA and JCM. But the bottom line is GHRH had a marvelous effect in this patient population, HIV lipodystrophy, to reduce visceral fat compared to placebo. I don't think people would argue with that p-value. But the curious thing was it had no effect to reduce subcutaneous fat. So it seemed to be a selective effect on visceral fat, which may have to do with the oxidative potential of visceral fat. It resulted in a physiologic increase in IGF-1. And I think because of its effects, it decreased de novo lipogenesis, triglyceride levels were significantly decreased in this group of patients. And basically, based on all this, with a lot more and a safety profile, this was approved by the FDA for the treatment of abdominal fat accumulation in HIV lipodystrophy in 2010. Interestingly, growth hormone went up for the same indication and was rejected by the FDA at that point. But because of our knowledge of this effect on abdominal fat and potentially effects on ectopic fat, we wanted to study tesamorelin on non-alcoholic fatty liver disease and HIV, and this paper was published in Lancet HIV. And this was a really simple design in which we took HIV patients on stable antiretroviral therapy. So not the guy you were presenting earlier, but patients stable on therapy for years, with hepatic fat more than 5% on MRI, without significant alcohol or viral hepatitis. And our primary endpoint was hepatic fat. But we did liver biopsies at the beginning and end. We used MRS to look at the liver fat. And we had 31 on to say, basically 1-to-1 randomization. In the baseline, you can see that the hepatic fat was high, well above 5% by design in each group, and even the percent with NASH was about a third. Again, we didn't require NASH, we required steatosis, so relatively early in the cascade I mentioned. The percent with any fibrosis was about 40-45% or so. The visceral fat was quite significant. The BMI was in the low obesity range. A1C wasn't too bad. IGF wasn't too bad. IGF is not a good index of growth hormone deficiency, as you all know, in patients. It's not a great test for that. So the primary results of the paper were as follows. The absolute change in liver fat was 4.7%. So that would result, that equaled a 32% relative decrease in liver fat versus a 5% increase in placebo. So very, very significant. And in fact, when you look at the percent that normalized to less than 5%, it was 35% versus 4%. And in the world of NAFLD, patients with more than a 30% reduction in liver fat are special because that reduction is what relates to improved histology. By Rohit Lumba and colleagues, and that was 60% who had a more than 30% reduction versus 15%. So on the fat, we had it covered, very, very significant and clear result. I wanted to place this in the context of other agents that are being developed, not to speak a lot about them, but just to show, that when you look at placebo-adjusted changes, we weren't too bad. This is 37 over here. Peg-Belferman is 32 if you do the placebo-adjusted. So we were, among the more significant agents, but not the most with respect to liver fat. But if you have to look at the placebo-adjusted change, and in our group, the placebo went up a little bit. We next were focusing on fibrosis, and because we had liver biopsies, and the percentage of people who fibrosis worsened was 10% in tesamorelin and 37% in placebo. And the ALT among those who had high ALT at baseline was reduced in tesamorelin versus increased in placebo. So again, significant results, not to reduce fibrosis, but to prevent progression of fibrosis. And then we looked at visceral fat, which we saw the same effect we saw in all our other studies. And the change in IGF-1 was physiologic, 116-point increase versus basically a nil effect in placebo. which was important. Now, we did not see a significant change in NAS score, but only a third of the patients had NASH. So what we did is we plotted this, and you can see that the change in NAS versus the baseline NAS in the placebo group was basically flat, whereas there tended to be a reduction. So the more higher the NAS, the higher the baseline, the more the change in NAS score in this group, in the tesamorelin group versus the placebo group. Further, larger studies are needed to address this important question. Now, many people said, is it safe? Is it safe for glucose? Because that is important. Growth hormone can increase glucose, obviously. In this particular study and in all our studies, even using clamp, it's been safe in terms of not increasing glucose, because I think it's relatively physiologic compared to growth hormone per se. In terms of adverse events, there was no difference in any adverse events, SAEs. There was, some increase in patients who had, minor myalgias, et cetera, and some increase in injection site erythema, but not anything that was significant, and in general was well tolerated. So I next want to turn to the more translational aspects of this study, which I think are perhaps among the most interesting, and show you a couple studies in which we have leveraged the transcriptomics and the proteomics in this study. So first, in this very study I just told you about from the liver biopsies, we did gene set enrichment analysis with the Broad Institute at Harvard. And we saw a number of gene sets that were significantly regulated by our therapy compared to placebo. First, upregulated was oxidative phosphorylation pathway. And this is really interesting. That goes along with what we know about growth hormone. And it's interesting to see it in the context of a clinical study. We had not seen that before. And the leading edge genes are shown in this cartoon, are really all part of the mitochondrial electron transport chain. So it's like evidence, some evidence that growth hormone upregulates this in a clinical study. And what was downregulated were pathways of inflammation, IL-6, JAK-STAT, inflammatory response, tissue response, epithelial, cell division, et cetera. So the fibrotic tissue repairs were downregulated, inflammation downregulated. And interestingly, the hepatocellular carcinoma favorable prognosis gene set was upregulated, which is a good thing, and the HCC poor prognosis gene set was decreased. So, I cannot say what this will do in terms ultimately of liver cancer, but at least by these gene set studies, it didn't seem to aggravate the genes that are implied in those pathways. So as a cartoon in our JCI paper, tesamorelin, GHRH analog leads to stimulating anterior pituitary function, increased pulsatile growth hormone, changing oxidative phosphorus, increasing OXPHOS, decreasing cell division, tissue repair, inflammation through this increased growth hormone signaling. And interestingly, these changes, for example, in cell metabolism, OXPHOS, inflammation, tissue repair, and cell division were all significantly related to the change in fibrosis-related gene scores. So in the directions anticipated. So as OXPHOS went up, the tissue fibrosis went down more, and vice versa for pathways that were thought to be related, like cell division and OXPHOS gene score. So this is pretty interesting, actually, and very strong relationships that we got through our biopsy in the context of treated liver disease with tesamorelin. So then what we did is we performed a proteomic analysis. And so we aimed to identify circulating proteins that are modulated by tesamorelin in association with clinical response in NAFLD. So we took 17 gene pathways that were differentially modulated by tesamorelin, and we looked at all the leading edge genes. And we did a proteomic analysis that looked at some of the genes, some of the proteins that were changing in the circulation versus in the transcriptome. And we overlaid these, and we saw some very interesting concordant patterns, particularly for three pathways: VEGF-A, TGF beta 1, and CSF. And this paper was just published in Scientific Reports this year. So looking at TGF beta 1, and comparing this is the plasma protein, the tesamorelin versus placebo, a significant reduction, and the change in TGF beta 1 related to the change in fibrosis score. So the more the TGF beta went down, the more the fibrosis score went down. And we know that TGF promotes fibrogenesis, so its decrease with tesamorelin is notable. And its relationship with gene set fibrosis score is interesting as well. Then the next protein was VEGF-A. This protein has a role in angiogenesis. It promotes proliferative activity of hepatocytes and has an important role in liver steatosis development and progression. And here we saw again a pattern where tesamorelin reduced VEGF-A compared to placebo. Again, same relationship, but here we're looking at NAS score. So the more VEGF-A was reduced by tesamorelin, the more the NAS score declined. And the last one that was notable was CSF1, macrophage colony stimulating factor 1. This promotes infiltration of monocytes into the liver. It affects proliferation of Kupffer cells and monocyte-derived macrophages. It works on differentiation of monocyte-derived macrophages and has a central role in liver fibrosis. And again, it decreased with tesamorelin. The change was related to change in NAS score and to the change in fibrosis gene set score. So interesting, we have proteins that are affecting inflammation and fibrosis that are appropriately and significantly regulated by tesamorelin, providing further evidence of the gene set, or the gene set data that we showed earlier, and the clinical data, of course, as well. So putting this together, I showed you this cartoon over here, but now we have further data showing that decreased CSF1, which it would affect the Kupffer cells, decreased TGF beta 1 affecting stellate cells, and decreased VEGF-A affecting endothelial cells. We also looked at, in another aspect of the proteomic analysis, at an inflammation panel using O-Link, the O-Link proteomic assessment panel for inflammation. And in a typical volcano plot, we saw a very significant node of proteins that were changing, that were interrelated, particularly with respect to inflammation and immune modulation. And this is a gene mania network. So in the systemic circulation, not only did we find proteins changing that were mirroring the transcriptomic liver pattern, we found other proteins that were changing very significantly with respect to tesamorelin that were suggesting an anti-inflammatory, immune modulating effect of tesamorelin. And this was published in Clinical Infectious Disease 2021. And the last study I'll talk about, which has not been published but is in preparation, was to elucidate a proteomic signature of hepatic fibrosis in HIV-associated NAFLD. And here we're basically comparing protein patterns in patients with fibrosis versus not. We looked at 183, and this is again in our HIV NAFLD patients, 183 plasma proteins in 2 high multiplex panels, O-Link, cardiovascular, and immuno-oncology, were assessed among people with HIV and NAFLD, and the protein levels were compared among participants with fibrosis stage 2, 3 versus 0, 1, and associated with clinical characteristics. And you can see here, based on the difference between, fibrosis, significant fibrosis and not, there were a number of changes and the degree of expression of these circulating proteins. And you can see just generally that the fibrosis stage over here is more red on the heat map than in the early fibrosis stage. And some of the proteins that were most significantly different between fibrotic and non included collagen, COL1, A1, IGF-BP7, and MMP2. And these are genes which are known to be associated with fibrosis. It's interesting that we saw this pattern in HIV, and there's many, many more proteins to investigate and interrogate that we've just begun to scratch the surface here. These are the top 10 differentially regulated proteins with FDR less than FDR corrected p-value less than 0.1. And you can see there's some interesting ones: galectin, osteopontin, OPG, MCP1, etc. And when you do principal component analysis, you do see a separation, the more to the left, the black dots, versus more to the right, fibrosis stage 2 and fibrosis less than stage 2. And the differentially regulated proteins do map to an interrelated network with immune and tissue repair nodes. So you can see the deep connections between these, particularly a tissue repair mode. And when you look at clinical correlates of these particular proteins, so red is positive, and the deeper the color, the more, and blue is negative, you can see that among these patients, those with higher glucose area under the curve had more upregulation of these proteins, and those with BMI as well. Interestingly, lower CD4 was associated with upregulation of these particular proteins, which is quite interesting to us. And you can see that that's shown here, and suggesting there's maybe an immune modulation of these particular proteins. We need to further investigate this. In conclusion, what I've shown you today is that NAFLD NASH is a major issue among people with HIV who have some unique mechanisms, epidemiology, and consequences of this disease. That there are a limited number of agents that have been tried to reduce steatosis and improve fatty liver and HIV, and agents which simultaneously increase hepatic oxidation, reduce inflammation and fibrogenesis, and immune dysregulation may be most effective in this regard and in general population. And tesamorelin is a GHRH analog which uniquely addresses perturbed growth hormone signaling in the liver of patients with NAFLD to reduce fat, inflammation, and prevent fibrosis. And really, further larger phase 2 and 3 trials are needed to assess for clinical improvement in HIV, as well as potentially utilization in the non-HIV population. Right now, this drug is only approved for lipodystrophy and HIV, so you can't use it in non-HIV patients, but it's an interesting question. So I think I'll end by thanking some really key people that were involved in this work in our unit, particularly Lindsay Foreman and Takara Stanley, my colleague at NIH. The study that I mentioned that was published in Lancet HIV was a U grant between NIH and ourselves with Colleen Haddigan and David Kleiner. Radiology, Martin Toriani, and particular thanks for our MGH hepatology colleagues, Kathleen Corey and Ray Chung. So I think I'll leave it there for now, and welcome any questions, and thank you very much for your attention. Thank you.
Thank you so much, Dr. Grinspoon. Who would have thought that a GHRNA analog would be useful for NAFLD in HIV positive patients?
I know.
It's a really interesting approach.
Yeah.
I have a question for you. Just looking at this, you mentioned about a physiological increase in growth hormone. Now, I know you mentioned the feedback loop is still intact, but have you noticed any indicators of increased risk of cancer in these patients as the growth hormone goes up? Because we worry about that in acromegaly.
Yeah, no, obviously that's a really important question. So just to make a couple points. First of all, interestingly, when you give GHRH to NAFLD patients, this is a group of patients whose IGF-1 is low to begin with, okay? Because I showed you the evidence that actually the sicker the liver, the lower the IGF-1 in circulation and transcriptionally. So number one, that's the people you're giving it to. Number two, the increase in IGF-1 largely brings IGF-1 back up in the normal range with GHRH. I'm not saying that's the case with growth hormone, but with GHRH, it is within the normal range in most cases, not all cases, but in the vast majority. But nonetheless, that's all speculation. To get to your question, There has been a data registry of every patient that ever got tesamorelin clinically for lipodystrophy. Over all the years, the FDA required that, and there was no signal in the phase 3 studies, and there's been no signal to date in this registry. It's still a relatively small number of patients, so I can't 100% say that it's free of any signal. But the FDA did not consider that a warning, if you will, although they did ask us in the company to watch for it in the future. Nothing has shown up thus far. And I think relatively unlikely given the physiology, but it is true that, as you give it to more advanced liver disease, yes, the IGF goes down, but maybe the stimulation for liver cancer might be a consideration. So it's all going to have to be evaluated very, very carefully, but so far, no signals yet. I hope that answers your question.
That does. And that leads on to the second one. I have no experience in this population, but how easy it is to get it approved via insurance, since it's seems to be such a specialized targeted drug?
You're asking about the tesamorelin approval for lipodystrophy, yeah. It's generally been approved by Medicare and Medicaid in most, and we haven't had too much of a problem in most states getting it approved. I can't say every state is perfectly easy, but certainly in the big major metropolitan areas, we haven't seen any problem. In Massachusetts, we're very lucky because the HIV population is very active, and there's actually a law by the Commonwealth that says that you must provide treatment for lipodystrophy if the person has lipodystrophy. So it's actually by law mandated that they have access to that in Massachusetts. But that, that's also the case. I think in the country now there's anywhere between a couple thousand people being treated with tesamorelin for lipodystrophy. So it is a niche drug, but the physiology is really cool, and I think the potential to expand into other populations is really, really important, which is why it's so interesting. I'm not an ID doctor, I'm an endocrinologist, but we're using HIV as a model of acquired lipodystrophy in ectopic adipose tissue that can be regulated. And that's been what's been so interesting for us, to use that model over the years.
Thank you. We have a question from Dr. Olansky. What is the mechanism for growth hormone and IGF-1 suppression by liver fat?
That's a good question. I don't know whether the IGF is down in growth hormone deficiency because it's just a function of GH signaling, low GH from the pituitary, or a further effect on independent of GH on IGF transcription. I suspect it's both, and particularly the latter. There's changes in the GH receptor with disease concentration as well. So and I'm not sure why IGF goes down. Maybe it's a physiological response. I'm not sure, but the ultimate effect of it is to be associated with increased fat and fibrosis. So I'm not 100% sure why that is the case, but I don't think it's just because growth hormone levels are low. I think there's some actually hepatic regulation of IGF-1 independent of that as well, given the context of liver disease.
Thank you. A question from Dr. Feynman. Should tesamorelin efficacy be compared with other potential agents like pioglitazone or GLP-1 agonists instead of placebo? And the second part of that is, how does efficacy compare with gastric bypass?
Yeah, those are great questions. When you do trials, the first time you do a trial, you want a placebo comparator, and every company that goes in and every investigator, that's what you really ideally want, because obviously it's harder to show an effect versus another drug that's somewhat efficacious. But ultimately, that will be the test, a comparison of these different strategies. Now, they do different things. The GLP-1 agonist reduces weight, It's a great insulin sensitizer. It has been shown to affect liver fat and other aspects. It doesn't reduce visceral fat as much, and I actually think it would be a great drug to use in conjunction with tesamorelin. If tesamorelin increases glucose, you could use the combination of the two. And ultimately, this will need to be tested. I think GLP-1 is probably among the leading candidate, GLP-1 agonists, leading candidates for this. And so I'm certainly not saying that tesamorelin is the only drug for this, but it's interesting in the context of the physiologic responses of low GH and IGF-1 and fibrosis in the liver and how it addresses that, which the GLP-1 agonist is a great drug, but it's not addressing that physiology. It's addressing the important physiology of insulin resistance, which I did mention in the beginning of my talk is critical to modulate. So I think GLP-1 is really interesting. And later stage studies will do it. Once one of those agents is approved, you will no longer have equipoise to do a placebo-controlled trial, but they're not approved yet. So you have the luxury of being able to do it at least for a little while longer.
Thank you. Thoughts about efficacy with gastric bypass?
Oh, yeah. So gastric bypass does improve liver fat, but the interesting thing about TSM, and I can't quote you the specific differences, but I'll just focus on the completely different mechanisms of action. Gastric bypass lowers your weight, which lowers your insulin resistance. Tesamorelin does not lower your weight. It lowers your visceral fat, but it leaves your subcutaneous fat intact. And subcutaneous fat is a good depot. So it's selectively, so it's completely different construct. One just lowers weight, visceral and sub-Q together, and lowers insulin resistance. Is a wonderful therapy for obesity. But for lipodystrophy, in which the subcutaneous fat is low and the visceral fat's high, gastric bypass is not necessarily the best option because the weight of these patients is not particularly high. It's BMI of 29, 30. So for the lipodystrophy patients, we weren't focusing on gastric bypass. I will say if you're severely obese and you have diabetes, obviously getting gastric bypass would be more useful upfront than tesamorelin. But for lipodystrophy, in some cases of generalized obesity, tesamorelin is quite useful. I'm not sure I can hear you. Sorry.
My bad. One thing I do want to point out is the picture you showed, the patient didn't even look like they would actually qualify for gastric bypass just based on the
That's
BMI.
right. That's what I'm saying.
For a BMI is less than 35, so
Right.
they probably would not qualify.
Right.
And I would worry about, you can't have such a targeted fat reduction with gastric bypass, which is what you mentioned.
Right.
Dr. Bush is asking about, I'm interested to know if growth hormone therapy could be entertained in other lipodystrophies like partial lipodystrophy.
Yeah, that's high on my list to figure out. That's a very good question. And I think my guess is yes. Not full generalized lipodystrophy, perhaps, but partial, I think, might be useful. I did show patients with lamin A mutation in one of my slides have very, very significant hepatic fat accumulation because the signaling through the insulin receptor is ongoing. So a drug that reduces their visceral component but leaves the subcutaneous component alone, which is a good component, may be very useful in that population, particularly those that have increased liver fat. So I think that's a very good idea, and we just haven't had a chance to do it yet. Okay.
Thank you. Any other questions or comments? Dr. Grinspoon, that's a very elegant research work that you have done. I am honestly very impressed looking at such great mechanistic research studies. This is wonderful and very different from what we usually see. So I'm glad you could present your research to us today. We would definitely like to hear updates in maybe a couple of years back to see how far you've gotten in the non-HIV population.
Thank you.
If we have no other comments or questions, we are going to end it here. Oh, Dr. Thayman, yes, please go ahead.